I've heard women, 80% of my union are women. I have heard women say, you know, with this $20 copayment, I'm willing to take my kids to get immunized. I'm not willing to get my mammogram or my pap smear because I simply can't afford to go. For lower wage income earners, the monthly contributions that workers have to make equates to a regressive tax on working families. That is, low income workers are paying a greater portion of their income towards the cost of insurance, while higher paid workers and executives are not paying the same amount of their income. So the U.S. healthcare system penalizes companies like GM or employers like Los Angeles Unified School District who want to provide decent benefits to its workers. By American standards, these employers have an old workforce. Its average worker is much older than the average worker at a company like Google. That has an immediate effect. Healthcare costs are a linear function of age. The average cost to insure a worker between the ages of 35 and 40 is $5,400, and for someone between the ages of 60 and 64, it's $6,400. It goes a long way toward explaining why GM, or Los Angeles Unified School District, has an enormous, for us, GASB liability, the Government Accounting Standards Board that requires that you account for your post-retirement medical benefits. While these employers are having to account for this liability, several years ago, it caused GM to go actually bankrupt on paper. The insurance system discourages employers from hiring or retaining older workers. If they do, they are penalized by having to pay more expensive insurance premiums, yet another example of the fatal flaws in our employer-based system. If the U.S. moved towards a single-payer national health insurance system, employees would benefit by knowing that everyone would pay a proportional amount of their income for the benefits. Would not be lost if workers were laid off. People could move from the jobs they hated, and the people stay in jobs that they hate to keep their benefits. Actually, people could go to work and be in jobs that they liked. The employer and the union could stop spending hours at the bargaining table talking about insurance benefits, with the end result being a zero-sum gain. We would finally get control of the cost, which would free up billions of taxpayer dollars that could go back into teaching our children. And thank you very much for having me today.
Our final panelists, we're very fortunate to have him here, is Dr. David Rabin, who, frankly, as I read the biography, must hold, by my count, 18 degrees from some of the most prestigious universities and colleges of medicine in the United States. Suffice it to say that those degrees and lifelong dedication to medical education have allowed him to write some 120 articles and 2 books on the use of healthcare services, long-term care, medicine use, AIDS, and other preventive services, and the consequences of financial barriers to the uses and accessibility to healthcare. Doctor, thank you very much for joining us.
Thank you for the introduction, and thank you all for coming. I think we all agree it's medical care costs that are the greatest barrier to extending coverage to everyone. One experience from which we all can learn about cost containment as we consider healthcare reform is the history of private plans in Medicare. Single-payer Medicare began because private insurers could not profitably insure the elderly, creating a crisis for the elderly and for their families, quite reminiscent of the experience we have in general today. 6 years later, in 1972, with the first Medicare amendments, for-profit private plan HMOs were permitted. The reason explicitly to save Medicare money. To make that reason explicit, the 1982 Tax Equity and Fiscal Responsibility Act began paying HMOs at 95% of the average per capita cost for a Medicare beneficiary, and additional benefits. But studies showed that HMO enrollees were healthier than average, and that Medicare beneficiaries, therefore, were subsidizing those that were in the HMOs. Despite these findings, in 1997, Medicare Plus Choice was initiated, expanding the availability of private plans other than HMOs, PPOs, and private fee-for-service PFFS plans, and increasing payments in areas with low fee-for-service costs, mostly rural areas, and subsequently in low-cost urban areas. These additional payments proved insufficient. Many private plans withdrew, many precipitously, leaving enrollees without Medigap insurance. Private plan enrollment dropped from 6.9 million to 5.3 million. The 2003 Medicare Modernization Act renamed Medicare plans, private plans, Medicare Advantage. They legislated additional plans, regional PPOs and special needs plans. Plan payments were further increased. The private plans incorporate supplementary Medigap benefits, and 2/3 incorporate Part D drug plans into a single plan and premium. Currently, nearly 11 million Medicare beneficiaries are enrolled in these private plans, 83% in plans with individual enrollment, aided by aggressive marketing violating, in many cases, Medicare advertising guidelines. Private plans speak of choice, and the average beneficiary now has a choice of 44 plans. But every private plan limits choice of providers, which is what most individuals want in the way of choice. More restricted provider choice is associated with lower costs. Thus, HMOs cost least, PPOs most. Premium cost seems to be the most important attraction for enrollees. 54% select plans with no premium, although they are paying the Part B Medicare premium. Enhanced Part D benefits with gap coverage are also attractive. These features imply lower cost sharing through cost sharing for benefits. However, these benefits for those chronically ill will pay out of pocket, cost out of pocket, another $3,600. Moreover, there may be a trade-off with quality, as initial quality evaluation of Medicare Advantage plans has not been reassuring. The most critical issue, however, we all agree, and for the nation, is costs. Private plans are paid an average of 14% more than the cost of care for a traditional Medicare beneficiary. PFFS plans, 17% more. And those plans neither manage care nor develop provider networks, though they are required to by 2010. They assume providers will accept whatever reimbursement level they set. If providers, however, do not accept the PFFS reimbursement, Medicare beneficiaries are uninsured at the point of service. Medicare Advantage pays more to private plans, sometimes providing additional benefits, even though plan enrollees are healthier, both physically and mentally, than traditional Medicare beneficiaries. The 5% of Medicare beneficiaries in poor health account for 43% of Medicare costs, so a tiny difference in the proportion of enrollees in poor health has huge implications for total Medicare Advantage costs. As for the additional benefits, OMB's Peter Orszag estimates that Medicare Advantage supplementary benefits cost Medicare $1.30 for every dollar of coverage, with no evidence of improved quality. Further, these extra benefits provided private enrollees go to those whose needs are less rather than those whose needs are more. Minimizing enrollment of the needy adds to the profitability of private plans, but exacerbates the financial viability of traditional Medicare. Since Medicare receives general tax revenues, all taxpayers, all of you in this room, and all Medicare beneficiaries are financially compromised by the MA subsidy.